You're listening to Addiction Medicine Beyond the Abstract, the official podcast of the Journal of Addiction Medicine. If this is your first time listening, thanks for coming. Addiction Medicine Beyond the Abstract is produced for your enjoyment and is focused on the latest journal-published research and science in the field of addiction medicine. Remember to add us to your favorites in iTunes, and you can also follow us on Twitter at ASAM.org and Facebook. Now, let's go beyond the abstract. Welcome back to another episode of Beyond the Abstract. Thank you so much for joining us. Today, we're sitting down with Dr. Nicolas Garel to talk about the link between stimulant use disorder and cardiovascular disease and how cardiology can be better integrated into addiction medicine treatment and care. A little bit about our guest today. Dr. Nicolas Garel is an addiction psychiatrist and a researcher at the Centre Hospitalier de Université de Montréal. Forgive my terrible French, Dr. Garel. I butchered that. I'm so sorry. He is an assistant professor in the Department of Psychiatry at the University of Montreal, an adjunct professor in the Department of Psychiatry and Behavioral Sciences at Stanford University. Dr. Garel completed his medical degree at the University of Montreal, followed by his psychiatry residency and clinician-scientist fellowship at McGill University, and later pursued advanced training in research and addiction medicine at Stanford University. His research program focuses on innovative interventions for treatment-resistant mood disorders and substance use disorders. All right, now let's get into today's talk with Dr. Nicolas Garel. I want to thank you again for taking the time to sit down and talk with me today. I'm excited for our conversation and I appreciate your time. So thank you very much. And as we typically kind of do with the podcast, I want to ask you a little bit about why addiction medicine, like of all the things, of all the fields, of all the areas of study that you could have chosen to work in and to get involved in. What was it specifically about addiction medicine that got you interested, and what has your journey in your career so far been like?
Yeah, thank you for the question. To me, addiction or substance use disorders is probably one of the most biopsychosocial and spiritual disease, with lots of different type of routes and way of intervening. So I really came into addiction medicine because I was struck really early in my training as a medical student and after that as a psychiatrist by how profound suffering in terms of emotional, social, biological intersects with substance use. And addiction is not just kind of a behavioral problem. It's a psychosocial condition with yes, biological substrates. So there's neuroadaptation and all dysregulation of stress response, but so much psychological drivers, from trauma to people who are more impulsive, less inhibited, less emotionally regulated. There's all the social determinants. I mean, going from housing and inequity, and there's also all this spiritual component of addiction with patients who have lost meaning, are totally disconnected from community, purpose, struggles with identity, and you need to take all those components into your treatment plan. Some of them are often overlooked in conventional medicine. So, I mean, to me, addiction medicine was really just a framework to engage with all those and all these dimensions. So not just symptom reduction, but relational healing, restoration of identity and agency, and really a way of practicing medicine with the integration of care that also attends to spirit as well as body and mind. So I think it's all this holistic stance that really has shaped my clinical work and research in the field. Yeah.
That's amazing. I love that. And, we're going to be talking about something interesting today. We're going to be talking about cardiovascular disease and how cardiology kind of integrates into addiction medicine. So let me start by asking you this. Why do you think that preventative cardiovascular efforts focused on risk factors like tobacco exposure and alcohol use rather than stimulant use? Why has that kind of been the case so far up to this point?
Yeah, I mean, I think historically and still to this day, tobacco and alcohol in terms of prevalence has dominated the cardiovascular prevention because of this very prevalent use, and the attributable burden of cardiovascular disease has been so high for decades, and it's still the most significant risk factors just by how many people are using tobacco and alcohol versus other type of substance. There's always been a very clear causal pathway also with smoking and atherosclerosis that has been established and integrated into guidelines really early. And I mean, in contrast, stimulant-related cardiovascular risk, cocaine, methamphetamine, has really recently re-emerged as a major driver of cardiotoxicity. I think because there's a more and more public health crisis, there's a resurgence of methamphetamine use globally, especially in North America, Southeast Asia, Australia, where, I mean, even now there's WHO call for action to take care of the stimulant use disorder crisis and kind of epidemic that is going on. So I think we are starting to see more and more stimulant-related complication in emergency department and hospitalization, and cardiologists are just totally, how can I say that? Totally surprised and in shock in front of those young patients with terrible cardiovascular condition. There's a new term now of MET-HF, which is heart failure, that we are seeing patients of 30 years old, 35 years old with really extremely terrible heart condition. So we are now talking more and more about this cardiotoxicity. But why, to go back to your question, tobacco and alcohol have dominated cardiovascular prevention? It's because it's historically really a way higher prevalence of use and a bigger burden on CVD across Western countries.
Mm-hmm. Well, you just mentioned a little bit about some of these risk factors from smoking and things like that. But I wonder if you can answer too, why are patients with stimulant use disorders maybe more vulnerable to cardiovascular disease progression compared with people that don't have, with non-stimulant use disorders?
So there's really in terms of the mechanism of stimulant cardiotoxicity, cocaine and methamphetamine especially exert such a powerful effect on the cardiovascular system through different type of mechanism. There's a huge catecholamine surge, so really a lot of norepinephrine release and dopamine release, which gonna really increase a lot in a very important way. High blood pressure, so really is going to create this tachycardia and hypertension that is a major stress for the heart. The heart that needs to continue work and push towards a very high blood pressure will eventually develop some sequelae. There's also direct toxic effect in terms of endothelial injury, very severe vasospasm, and microvascular dysfunction. So with this effect of vasoconstriction, because it vasoconstrict arteries with a repeated fashion, it's going to really create those injuries into the vessel walls. There's also direct myocardial injury to the muscle of the heart with this excess of catecholamines that really trigger oxidative stress, mitochondrial dysfunction, so how the muscular cells directly function at the intracellular level, with myocyte death, also really death of cells. And really we can see this accelerated atherosclerosis and arrhythmogenesis also. So it really promotes plaque instability and really a lot of electrical instability in the heart, so people can have severe arrhythmias and cardiac arrest. And really all these processes accelerate both acute potential events like MI, myocardial infarction, arrhythmias, but also with repetitive use, chronic processes like cardiomyopathy and heart failure. I think the rates of heart failure in California in the last 10 years increased from 600 to 700 persons, just to give you kind of a ballpark. And in contrast, many other substances, yes, like cannabis have direct injury, but a bit less of direct hemodynamic impact. And so I think there's definitely a higher toxic tropism for the heart with stimulant, both at the instantaneous stress on the heart and acute event, but also higher baseline propensity towards structural disease like heart failure.
That's really interesting. I wonder if you can talk a little bit about how you feel like cardiology can be integrated into addiction medicine.
Yeah, or vice versa.
Okay.
How addiction medicine can be integrated in cardiology and cardiovascular clinic. And there's some interesting programs or projects that I've seen that with preliminary data that are encouraging. We could discuss that. So I think this is one of the very exciting frontiers in clinical care to talk about true integration. So that means what? That means breaking down silos so that different disciplines like cardiology and people in cardiovascular health and people in our field like addiction treatment really could develop and have this sense of co-ownership in interdisciplinary teams. I think we need shared care models. And that means also just in terms of geographically in clinics, co-location of cardiology and addiction medicine providers to streamline assessment, referral, follow-up, to make sure that on both sides there's routine cardiovascular screening for patients with stimulant use disorder, not only in acute setting, but longitudinally. And I think this is very important because it's really young patient, and often when we are in front of young patient, we think less about cardiovascular disease, but in stimulant user, we should right away think about that and ask and do tests to look at how the heart is functioning. And I really think that we need multidisciplinary clinics. So there's a project, by example, in San Francisco that's seen when cardiology and addiction medicine work side by side with some contingency management approach. Contingency management is a type of psychosocial approach that has a lot of evidence in stimulant use disorders where you reinforce a certain behavior. By example, if you keep having a negative urine test, you receive either money or kind of a gift to reinforce it, and it's one of the approach that has the most evidence in stimulant use disorder. So they included the contingency management approach in cardiovascular and cardiology clinic to improve engagement among patients with stimulant-associated cardiomyopathy. And they kind of seen very interesting result of increased engagement, and you can have an effect on increased compliance with medication also. So this is exactly the type and example how you could have integrated care where addiction medicine brings up kind of the knowledge and the expertise of psychosocial or even pharmacological intervention of stimulant use disorder to work side by side with cardiologists who will take care of the heart disorders. Because one of the big problems with stimulant use disorder population is low attendance in care, lots of dropout, loss to follow up. So just by increasing engagement in care and making sure that patient comes to follow up, you definitely have a better impact on their care. And another thing I think that is very important is training and systems change. So I think cardiologists should be trained in substance use disorder screening and harm reduction principles. I really don't think this is strictly for primary care physician or family doctors. And I think that, again, it goes through even trainings when people are in school to have this kind of reflex and conception that screening for use is part of every physician job and not only addiction medicine specialist. So I think this is this type of co-ownership that we should put emphasis on.
It's interesting because I have heard other doctors before talk about this fact that regardless of the field you're in or where you practice and what you do, you're likely to come across something to do with addiction at some point. So you should have some kind of knowledge and some kind of education around how to at least identify and treat it. So I'm wondering, you touched on it a bit here and you mentioned a few things, but what do you feel like are some approaches or maybe some treatment strategies that might be really beneficial for individuals with stimulant use disorders, especially if we're talking about trying to mitigate some of these cardiovascular disease risks?
Yeah. So I think what is very important to say is that the mainstream approach and mainstream treatment of stimulant use disorder are psychosocial intervention. So we don't have any FDA-approved medication to treat stimulant use disorder. There's some off-label use of different type of medication and agents. The ASAM new guidelines is a very well done and extensive summary of the literature with clear recommendation and indication of what should be maybe tried or not depending of the situation. So for people who are listening who are interested in terms of treatment strategies for stimulant use disorder, the new ASAM guideline is just really a magnificent piece of information. In stimulant use disorder, if we go into the psychosocial intervention, as I was saying, contingency management is consistently the most effective behavioral intervention. It's really where there's the most evidence. In the United States, it's probably the only place in the world where it's applied in real world setting and kind of scaled. Even at a state level, there's the California Contingency Management Program. In the Veterans Affairs, there's contingency management programs with very interesting result. Recently, there were publications showing that contingency management decreased the risk of mortality in stimulant use disorder, which is always kind of the most impactful things we can do, decrease mortality with the magnitude of effect was around 42% of decrease. And just to give you a comparison, this is usually what we have as a reduction of mortality in opioid use disorder with buprenorphine, with Suboxone. So very important. That needs to be replicated, but really contingency management is the most effective behavioral intervention. Then there's cognitive behavioral therapies, motivational interviewing. There's also an approach, community reinforcement approach, that is also grounded in operant conditioning, so increasing reinforcement to make people do behavioral change and decrease their use. But you work in the community trying to increase like natural or not substance-related reinforcement for people to decrease use. So there's different type of approach, but definitely contingency management, community reinforcement approach, and CBT, cognitive behavioral therapies, are the intervention that have the most evidence. And as I was telling you, there's also some pharmacotherapy off-label that have been tried and are different if you're treating someone with cocaine use disorder or amphetamine use disorder, like methamphetamine, with a different type of agents like mirtazapine, which is an antidepressant, Wellbutrin, Topamax. There's also now more and more people prescribing psychostimulant, especially when there's comorbid ADHD. So, but that is not FDA approved, and we need to remember that psychosocial intervention are the mainstream approach. And then there's all the community reinforcement approach like AA and community group, where there is a bit more of a holistic and spiritual and community care that needs to be proposed.
Shifting gears just a little bit, I want to look ahead a bit, and I want to ask you about what the future kind of holds from this retrospective cohort study. What kind of questions came about, and what kind of research studies do you think would be able to address those questions, down the road?
Yeah. So, this cohort study that we did that showed that stimulant use disorder are at higher risk of major adverse cardiac event than those with non-stimulant substance use disorder. The thing with this cohort study, I think that was interesting, and most studies usually compared cardiovascular risk of a substance use disorder to the normal population and people who are not using. That study, we compared stimulant use disorder to non-stimulant use disorder because they will share much more more similar demographic and things like that. And we did some high-dimensional propensity-score matching to match on other things than the use. So it really showed a higher risk of MI, cardiac death, HF, and also combined. I think it raised several critical directions for future research, like prospective longitudinal research. What we did was retrospective. It's less rigorous. So following patient over time with detailed cardiovascular phenotyping to map progression and reversibility of subclinical disease, because this is what is interesting, and this I think needs to be retained, is some cardiac toxicity are reversible when people stop using and there's treatment, until it is not. So there's really a critical period where we can intervene before people develop chronic and irreversible cardiac toxicity. I think there's also mechanistic studies that should be more done, so exploring molecular pathways of stimulant cardiotoxicity. There's also, I think, and this is where I stand the most, because this is what I do in terms of research, clinical trials. So intervention trials, so a test integrated addiction cardiology care model, by example, like the Heart Plus, in a randomized or quasi-experiential design to quantify impact on heart outcome and substance use. For the moment, it's more kind of what we have in the literature is description of program or pre-post, but it's not controlled studies. So increasing the rigor and the methodology to really show that integrating care has a big impact. Social determinants intervention also, so evaluate how addressing, we know that clinically, but to show it, housing stability, access to care, and trauma modifies cardiovascular trajectories among stimulant user. I think this is all pretty interesting future research questions that are raised with this type of study we did.
Yeah, this is really interesting. Completely changing directions now as we come to the close of our episode. This is one of my favorite sections. I get to ask you for some advice and some wisdom. And we get some great answers, and I love listening to you guys kind of share a little bit of wisdom with our audience and some of these younger medical professionals. So I would ask you, Doctor, what advice would you give to not only the upcoming generation of addiction medicine professionals, maybe just getting interested or involved in the field, but maybe also your younger self? What do you wish you knew when you started in the field that you know now?
Yeah, and I will tell. I'm a young physician, so I have a bit of an imposter syndrome to even answer this question, because it's not anchored in a lot of years of experience. I would say, to myself or to the next generation, stay curious and clinically humble. Addiction is a difficult field, and this intersection of mind-brain society is very complex, and we need to stay humble. And unfortunately, in our field, there's sometimes a bit of dogmatic approach. You're either an abstinent-based physician or a harm reductionist, and there's gang and kind of to stay in a grounded in evidence, listening to patient, being humble and not rigid in our way of seeing what we can do to help patient, to build bridges across disciplines, between, again, certain type of a specialty that have not necessarily a long track record of collaboration between cardiologists, psychiatrists. We need teams, and really having an approach that is centered on the whole person. So always keeping this biopsychosocial lens and cares that respects people's value, culture, spirituality, that definitely leads to better engagement and outcome. And to be advocate for systems change. We are very resistant to change in medicine. A physician is not the discipline where people are the most open to change. So to push for change, to push for prevention, integration, not isolation, are the future of addiction medicine for sure too.
Amazing advice. Dr. Nicolas Garel, thank you so much for taking the time to talk with us today.
Thank you so much for the invitation. I'm very grateful.
This ends today's podcast. Thank you for listening to Addiction Medicine Beyond the Abstract. All of today's show links can be found in the show notes. Remember, you can preview additional abstracts at journalofaddictionmedicine.com. This program was produced by the American Society of Addiction Medicine.